Thank you. It certainly is a pleasure being here. Laurie and I left Toronto this morning at 6:30 and got caught in the rain, but we made it thanks to a little gadget she has that told us how to get here. So in Toronto, we know the government's priority was EDALC. The Toronto Central LHIN and the Toronto Central CCAC got together and made a slightly different decision. It's Toronto after all, Toronto never do anything that they're told to do. However, the Toronto Central CCAC have been participating in a project through the Change Foundation called IHI Around Quality. So both organizations saw this as a quality initiative. We thought the whole notion of ED and ALC was really a quality problem. People were in the wrong place of care. We needed to take it on. So we focused on it as a big dot. And by doing that, it meant that we were not going to do 1 million projects, 1 million initiatives. We were going to go after the big dot, and we were going to go there. So in doing that, we focused on accountability, and heavy emphasis on accountability. We aligned a lot of initiatives, and we knew we had to change culture. So that was a big focus. The LHIN at that time broke all the LHIN initiatives down into 3, as did the CCAC. And they were very clear. They were going to spend some time and effort in preventing people from going to emerge. They were going to focus on flow to get people through the acute, and then they were going to look at the post-acute, which was home care, etc. So all the initiatives of the LHIN and the CCAC together lined up under those 3 kind of agendas. This has been our success to date. Just some background information. The Toronto Central LHIN has, along with Mississauga Halton, the fewest number of long-term care bed ratio in the province. We also had no new beds coming on stream. And we had about a 16% occupancy of people in hospital with ALC. We set a target of 8% ALC. We knew there would never be a 0% ALC, but we thought 8% was the target. Coming from 16 to 8 in an area with no new beds coming on stream and fewer number of beds was quite aggressive. And frankly, we all thought we were crazy, but we thought we wouldn't get there. So today we're at 9%, so we're almost there. So I think this is a significant shift, significant change. How did this happen? And it happened from a number of commitments and initiatives. One was the ownership for this stayed at the LHIN, the CEO of the hospitals, that they're 18, and the CCAC. And so we owned it, kept it there, and brought metrics. Give you some examples. The graphs you see there is a kind of report that the CCAC each month circulated to the LHIN and to the hospitals. And when we met, this information was brought to the fore. The one thing we could count on in Toronto is that hospitals are competitive. So the first time we began to put up the data, everybody paid attention. I remember a lot of the staff saying that the data isn't correct and had a lot of concern about the data. The CEOs, or most of the CEOs, took what I thought was a leadership position and said, if the data is incorrect, fix it, because that's the data we're going to use. And we began to get improved data quality. But also, they all agreed that they would always put up their name and their data so everybody could see who was where along the continuum. And we thought that was a significant progress. And I think that's been very, very supportive in terms of driving the agenda. This is another example of rehab and complex continuing care, the kind of report that goes again to the LHIN, to each hospital. They can see where they are, and they can see how they're comparing one onto the other. This is our overall intervention of Home First. So this started way higher. We were about 600, and then we brought it down with a lot of work, and then implemented Home First. And then we started to see improvement, and then it stopped. And then we had another infusion in focusing more on the complex continuing care and rehab hospitals. And then we saw improvement. And then we took off the long stay patients and started to pay a lot of attention to that group. At that point, I have to say, we had about 150 individuals in the 18 hospitals that were in hospitals greater than 40 days. And some of those that were in there greater than 40 days were in hospitals for up to 5 years. And so we then, the CCAC reassessed each of those individuals, and they were broken down into 3 groups: long-term care vets, behavioral, addiction and mental health. And then we formed some subgroups, each of those subgroups led by a hospital CEO. And their mandate was that they had to create a cross-sectorial table. So the LHIN issued the mandate, we had an agreement, and we had metrics and commitment and a time frame to which they had to report back. So for example, the previous speakers talked about the chronic vents. There were 8 chronic vents that had been in hospital for a number of years. So to date, we have successfully discharged 4. 3 have died during the process, and 1 just refused to participate. That's a systems issue we have to come back to and deal with. So Anne-Marie Mellick from West Park lead that group, but at that table we have housing, social services, community, attendant care. That's the team that is now designing the system. The other part of the work they have to do is not only to take care of these individuals, but they have to now design a system to prevent the future creation of long-term individuals. There's a similar project underway with addiction and mental health. But this focused attention to this initiative, because it's a big dot, forced the LHIN to also continually evaluate all the other initiatives the LHIN had, sorry, and actually turn off some of those programs. They were all nice programs, they were all good programs, but once you take the big dot quality approach, you do get very focused on what is yielding results, and you stay with it, which is what the Home First has done. We just stayed with it, stayed with it, stayed with it, and we're now, so today, they're down to 70 individuals in hospital longer than 40 days, where we started at 140 4 months ago. That's the kind of focus. I put this slide in to show what happened to our aging at home dollars from a LHIN perspective. So the first year of aging at home, 16% went to Home First. This year, we're up to 50% of the aging at home dollars to Home First. Why? It is the project that was yielding the best results in achieving the big dot aim, which was the ED-ALC reduction. So, and that's a particular strategy that has been employed to make that happen. I'll take a minute just to talk about this other LHIN initiative. This is integrated care for complex seniors. What we've done here as a LHIN is to look at that 1% of individuals that for us is using 25 to 30% of all the healthcare dollars, and said the only way we can now drive quality and cost is to actually begin to segment the population and design programs around the populations. Sandra mentioned that earlier, several people mentioned that earlier. What the Toronto Central LHIN has done is to have is now running a pilot of 120 individuals in that population with ISIS doing the evaluation. And they are accountable for this population and their metrics set. Readmission rate is being looked at. We expect to see a 20% decrease in readmission rate for this population. Admission for ambulatory care is also targeted for reduction. The reason this was designed this way, that the CCAC has accountability for these 120 clients, is coming back to scalability. What we do know is that for this high population, we cannot have every single family physician managing this population themselves. As the CCAC do not have enough staff that would staff every physician unit. So it's about targeting this population and creating a project. The one thing I'll say around this project is all parts of the system have signed an agreement around how this population will be served. So that if they need a geriatric assessment, it will be done within 24 hours. Whatever the needs are, will be done, and now primary care will also do home visits to keep this population home. And in order to make sure that everybody in the system meet their obligation and their agreement, we thought it was important that we had to hold one place accountable for ensuring the process across the system. This is a kind of, we're relentless about performance measurement and making the data available to the projects, to the organization, to the CEOs, to the boards, and so that this is the kind of information we are producing. I'll try and wrap up quickly, but I also wanted to take this opportunity to talk about the Toronto Central LHIN. What we've done is to have revisited our strategic plan. The first two columns, people have easier access to services, is the IHSP. Those two columns resulted from the integrated service plan that all 14 LHINs did together. And we saw this LHIN present theirs earlier this morning. We have kept that in place, but recently our board just approved a new plan. And there are two new columns on the plan. The one is around our people, which is about the LHIN itself, building our internal capacity. And the other one is around the excellent care for all legislation and how do we implement and embrace it. So I'll just give you, and I must say, we have no embarrassment about stealing from anybody, and we unashamedly do that. So that you will see in the next few slides where we have stolen from Jim Easton. We give credit wherever we go, but we just stole his stuff. So you can recognize the cogs and the wheels and the machinery. So what we've done is to take the IHSP and created the various machineries around each of the projects. And now we bring them all together because together they have to then generate the metrics that we have, that we report against. So that's how those pieces work to deliver on that part of the strategy. I'll spend a few minutes on this part of the strategy. And under the excellent care for all, we took the for all seriously. We think we cannot do for all unless we know who all the people are who are getting care. We don't know in Toronto, for example, how well our Aboriginal community is faring because we do not collect information on Aboriginal people when they turn up to the hospital. So I have no idea whether in the readmission rate, whether the Aboriginal community is getting a higher readmission rate than anyone else. Don't know that. How can I say I've achieved excellent care for all if I don't have the basic data? So under the quality agenda, we're going to take 3 of the indicators from the Health Quality Council. And we know one already, readmission rate. But we're going to work with the field and with some clients, pick 3, and then hold each sector accountable for their contribution to that metrics. So I can hold hospital accountable for readmission, but they're really not in charge of that. So we're holding the CCAC accountable for their contribution to readmission. We're going to hold long-term care accountable for their contribution to readmission, additional mental health. So we're going to take this year to not only figure out the 3 indicators, but what the metrics we're going to use that will move that indicator as the big dot. And next year it will be in everybody's service agreement. We're going to do the same thing for equity. We think equity is key. For example, we did a quick survey and we knew that if you lived, Toronto Central LHIN is at Bloor and Sherbourne. And if when I sit in my office, to the left is Rosedale, to the right is St. Jamestown. And those 2, either side of my office, is the biggest extreme in income. And we looked at the data, and if you lived on the left, you got the diabetic protocol we heard about. If you lived on the right, you didn't. And the people on the right are the people who can't afford the foot ulcers and the various things. So that's an issue. We think that's an issue. We're articulated as an issue. Healthcare providers very often don't like to talk about it as an issue because we're all good people. We don't like to think we discriminate. We don't deliberately, but we do when we begin to talk about impact on groups of people. When I go outside of Toronto, people often say to me, that's a Toronto problem. Interestingly enough, I don't think it is. I think it's a problem that's everywhere as we move forward. So equity is another agenda item for us. And we do know the one we're going to do in equity is to get everybody to begin to collect a different set of data elements. Race, income, place of origin, language, and we have a pilot project. That's the only way we're going to know who we serve and who we're not serving. And we cannot really get to quality if we're not serving all our folks well. The last piece is assisting planning and capacity. So the LHIN, under this strategic plan, have a few initiatives and agenda that is talking about how are we going to build system capacity. And we don't think we can really get the quality agenda until we have some significant longer-term capacity building plans in place. And so that's the third piece. The last piece is the internal capacity to the LHIN, because we see that in the middle, we can neither do the left or the right properly if the LHIN, as a LHIN, we don't strengthen internally our data management, our access to data, and we then can track things and put things back out to the field and to the public, etc. So we have a number of initiatives internally. One of which actually is a report that we need to give to the field, some metrics about how well are we doing as LHIN back to the field. Not only our own staff, but to ask our providers to also tell us what metrics we should be doing and how well are we doing. So that's the building the internal capacity piece. So that is our strategic plan.